Attendees are in listen-only mode.
Well, hello and welcome to the ABCs of MIPS. I'm Carol Flower with High Tech Answers. Thanks for joining in on this monthly series devoted to the MIPS program and as well as other incentive programs through CMS. Today we're going to be talking about scrubbing data submissions for 2015 MU, PQRS, and VBM, as well as touching on a few things related to the new final rule on meaningful use that just came out a few weeks past. Our expert, of course, is Tom Lee, founder and CEO of SA Ignite. Tom is a national thought leader on these incentive programs, and we interview him every year at HIMSS, and glad to have him on board to help shepherd in and lead this monthly discussion on the MIPS program. Joining him, of course, is Beth Hauk. She is VP of Client Services for SA Ignite and a Meaningful Use expert. Also, I think with a national reputation, although she might be a little shy about that. Hey, Beth. Hey, Tom. How you guys doing?
Doing real good.
Hi, Carol.
Hello. So just to remind the audience that we're going to go through some information, and then we will leave the second half of today's event and broadcast to a Q&A. So I'm going to go ahead and put myself on mute, and Tom, I will see you back on the Q&A, and I'll turn over the PowerPoint.
Sounds good. All right, let me get mouse going. Okay, great. So, boy, lots happened since our last webinar. First and foremost, we've really seen how the 2015 Meaningful Use Modified Rule has further played out in the field. And I'm going to invite Beth to say a couple, sentences about that in terms of how it's really going now out in the field. Beth?
Sure, thanks, Tom. I think overall we've heard cheers from every client out there. I think everybody's very happy to see how much they've really streamlined MU, how much they've simplified it, and then in particular for some of those patient engagement measures where everybody was having some difficulties, they've lowered some thresholds and made it simpler for people to reach MU. I think what I'm most excited about and what SA Ignite is most excited about is that this looks to be something that will be steady in the market for a period of time, and we haven't had that for a while. So I think everybody's excited to just dig into these rules and have them play out over the next 2 years to prepare themselves for stage 3.
All right, fantastic. And in our Q&A session, we will certainly come back to some questions related to MU and potentially also the modified rule. So on the PQRS value-based modifier front, really the big news has been everyone trying to digest and understand their 2014 QRUR reports that state what their quality and cost scores are to really impact 2016 payment adjustments under the value-based modifier program as well as PQRS program. There was a revised set of QRURs that was just released several days ago. Many of you should have gotten emails from CMS to encourage you to go into the portal, CMS portal, and download those. For the most part, changes around the edges, around some of the quality scores. But really the big thing that it corrects is that, as we talked about last time, there was actually an erroneous penalty, value-based modifier penalty, particularly for EHR direct filers, whereby they were determined erroneously to not have met the minimum value-based modifier reporting requirement. And that has since been corrected, really. It should be corrected in the vast majority of these revised QRURs. But the other thing it relates to is on November 23rd, which is coming up in a few days, is the final deadline to file an informal review request for both the VBM and the PQRS programs. And a lot of those requests recently have been around EHR direct filers, okay, because of this problem. So just keep that in mind. Take a look at the revised QRURs and contact CMS if you've got questions, particularly between now and November 23rd. Okay, and that's that second point there. So now let's kind of go and sort of set the stage for today's discussion. We're sitting here on November 19th, and really, if you look at your 2015 performance, it's pretty much already set. There's a limited number of weeks left in the year. Programs like PQRS are value-based modifier full-year programs. Even the 90-day period for MU is already halfway through for the last 90-day period that would be available for meaningful use under the modified rule. And so then the question is really at this point of the year and going to submission season, how do you actually maximize your data submissions given that your performance is pretty much already set? Okay, we're going to really explore this question from a number of angles. And Beth and I are very happy to also announce we got a couple free offers as well for all y'all to think about, consider at the end of this. So, so today, let's go through. We're going to go and kind of talk about this idea of scrubbing your data submission. What exactly does that mean? Well, we're going to use an analogy to claim scrubbing. Well, what is that? We'll talk about that as well. And then we're going to talk about first MU. That's going to really lead us through how can you actually scrub the data for MU after the performance year or period is already over, but prior to when you attest, to actually squeeze every little bit of incentive or avoid penalty for as many providers as possible to the greatest extent possible. Same thing for the PQRS value-based modifier side. I'll talk about that. What can you do after the fact? What can you do even after the performance year, but before you press the submit button to really get the most out of it? And then we have these free offers that I'm going to talk through to really kind of open help to the community here in terms of how you can really help do that for these respective programs. And then we'll get right into Q&A. Okay. All right. So let's go forth on this. Okay. So let's first talk about like this idea of scrubbing. For those of you who really worked with medical billing or back office revenue cycle, particularly in the fee-for-service world, which we know is now being upended by all these programs, I'm kind of a fan of the dummy series, because I'm a dummy about many things, and just as a point of entertainment, as I just took this definition from the Dummies Guide for what is a clearinghouse in medical billing, and in what is called claim scrubbing. Clearinghouses check the claim for errors and verify that it is compatible with the payer software. So if you think about meaningful use and attesting, or value or PQRS and you're attesting, there's kind of that same design pattern, right? You're at a point in the year, or soon will be, where the data already is what it is. Your fundamental patient data and codes, and they are what they are. But are there things you can do after the fact with that data to enhance it in an appropriate way that's actually going to maximize your opportunity financially or otherwise? Okay, same idea. So just to kind of visually reinforce what I just said there, here are some actual examples that we've talked in a number of our webinars about what you can do after the performance year is ended, but before you press the submit button. Okay, we've talked about, and we'll come back to in a moment, just that for example, for the PQRS program or for the value-based modifier program, which measures you select to submit, which may be a set of measures that's different from what you've been tracking the whole year, but what measures you actually select to submit can have a large unexpected impact on your QRUR quality score. Okay, that's one example. Meaningful use with menu measures and things like that. I think a lot of you have been exposed to that. The other thing is, in terms of scrubbing, is how can you remove risk from future audits? And there's a lot of things around, is the data consistent with itself, that actually are tied into a lot of the audit triggers that CMS is looking at, both for MU as well as PQRS audits now are growing in number. CMS has actually hired at least one third-party firm to conduct audits of PQRS, separate and apart from the registry vendors that may be auditing you as well, to really look to see if you can back up your submissions. And sometimes you'll look for inconsistencies in your data that we'll get into in a moment that can trigger that. Okay. Now, the third part of scrubbing is that there's a myriad of completely legitimate, ethically appropriate ways to increase your measure numerators even after the performance year is already over. Okay, and we'll talk about some examples of that. How can you, through your data extraction efforts for a number of these programs, increase your numerators, and then how do you figure out which numerators are going to be the most important to actually put that effort towards? Okay, there's ways that you can do that, and that's actually part of what we're going to offer for free within our at the end there. Okay, the last thing, and Beth is going to provide a number of examples, or has provided, as well as has provided a number of examples around meaningful use, for example, is that it's important to really get a handle on the status, the current status of your provider within any given program before you get deep into the data submission process and far ahead of any deadline that you may be up against. Because you can have a case, for example, where an MU provider, they've gotten lost in the shuffle and you never got their payment from the previous year. Well, guess what? If that pay cycle has not completed for the previous year, CMS isn't going to allow you in many instances to go forward with your 2015 submission. Now, that would be not a good thing to find out on February 28th, February 27th. Okay, so how can you avoid some of those things? And the benefits, I think, are pretty obvious, and we sort of alluded to those. So, all right. Okay, now I'm going to hand over to Beth here, and she's got 2 slides, and so Beth, go ahead. Beth, are you out there?
I'm sorry, Tom. I did the age-old kept it on mute thing. So hello, everybody. Okay, hello, everybody. I'm not sure how many of you were on a previous webinar, in particular the last one. But one of the what we talked about in the last webinar was that we were trying to give you some ideas of some things that you could do ahead of finding out what was going to be in the modified rule so that you could still prepare yourselves for MU. So some of the things that I'm going to talk about are in line with what I talked about then, because really, some of the scrubbing that you can do can be done, and I recommended that you start to do really some right away. So Tom gave a perfect example with the providers and just trying to find out whether or not you have been paid for that provider in a previous year. So our experience working with a ton of different organizations is that there have been places where you go to a test and you find out that the provider has been stuck for whatever reason in locked for payment from the previous year. And when that happens, you have to then call CMS at the height of the CMS waiting time to try to get them released so that you can attest for the next year. So that's a really simple example of some things that you would do to make sure, number one, make sure that all of your providers have already been paid for, to just scrub and make sure that the right people are prepared to be attested. But also there's some other, I think, special cases that I wanted to talk about. One is related to the Medicaid, Medicare clarification that came out in the modified rule. So what had happened is that you no longer can switch programs. So somebody, if they were in Medicaid, you can no longer switch them to the Medicare program. And if you don't meet the Medicaid threshold for 30% or 20% if you're a pediatrician, then you're kind of stuck where you can't be in really either program, but you're not attesting anywhere so that you can avoid penalty. So what the modified rule came out and explicitly said was, we're going to give you an option for being able to still attest for these ineligible providers. So now you have a reason to make sure that you definitely know what people's previous attestation history was so that you can make sure that you attest for them with the right program and recognize that you can attest for those people as opposed to just skipping them because they fall into this gap. The other types of things that I think fall into the gap and that you need to make sure that our providers are cleaned up so that you know which providers you're attesting for are, number one, newly onboarded providers. It's not unusual for, I say, people to just punt on that because it's hard to either collect their data from their previous location or to find out what their attestation history is or even to get their proxy access. But the impact of not attesting for those people still will follow you, and for their Medicare charges, you will get the penalty 2 years from now. The other key pieces of information, just to remember, people that practice at multiple practice locations, they do, by CMS regulations, and you do need to combine the EHR data. If they're working on a certified EHR at multiple locations, you are supposed to combine that data. And then as well as kind of making sure that for people that were either changing EHRs or going live for the first time, that you have met the 50% threshold so that 50% of their encounters were done on a certified EHR. And then lastly, one of the painful ones that we see is just that for whatever reason, perhaps the practice has been acquired by somebody, perhaps there's been some restructuring related to the group NPIs that people work under, you need to make sure that you've re-registered those providers and that the PAYCO system is still connected to the EHR incentive system in the way that you would expect. So you can find that out by simply registering the providers, and when you do that, you'll get an error if something was wrong. The second category of things that I think is important to scrub is what I would call just generally a category of exclusions. And because the modified rule is so much simpler and the amount of exclusions you can take are simpler, this is not as onerous to document. But I think the key two items are that need to be documented is, number one, what is your organizational policy related to taking exclusions? So if there is, even for the basic, should we take the exclusion if you met the measure but not if you didn't meet the measure? So, when do you take the exclusion and when do you go ahead and just submit data is a policy that an organization might make, and then just document the reason you did it. Along the same lines is the last column, which is the interpretations. So again, you're going to be audited. You can be audited up to 6 years from now, and you will not remember what your interpretation was at the time that you were submitting that data. So to support all of the information that you're submitting, you need to be able to document when you interpreted a measure in a certain way based on whatever documentation is out there, published in CMS, and there have certainly been a lot of updated FAQs lately, as well as when you're doing a workflow that's outside of the EHR recommended workflow, but for which that is also according to the regulations. So it's very common that obviously people are going to choose different workflows by which to collect the data for a measure, but it's important to also have the documentation to support why that still meets it. You can go to the next page, Tom. Okay, so then I want to point out, and I mentioned it on the last page, that the modified rule makes all of this scrubbing quite a bit easier. I want to point out a couple key points from the rule that I think will be helpful to you, both in your efforts to document some of the exclusions and some of the scrubbing that you're doing as it relates to interpretation and exclusions. So one is the public health measure. So when the modified rule came out, I think there was a little bit of a quick frenzy where everybody was worried about how do you take an exclusion for a public health measure when they're saying that any specialized registry counts. And where you don't have the list of all the specialized registries, you're like, how do I take an exclusion for all of them because I don't even know which ones they are. So CMS pretty quickly came out with an FAQ to clarify that. So it has made its rounds in a lot of the public sites out there, but I have encountered a number of people that still don't know that it's out there. So I highly recommend you read it. So the link is included in the document, and so you can be able to pull it out of there. I think it's FAQ 12985. So what the rule basically says is we did not intend to make this more complicated. If you were not intending to submit this public health measure in 2015, then you can take an exclusion for it. So even if you are a stage 2 provider, so you are not required to do 2 public health measures in 2015 if you are a stage 2 provider that was not intending to use the public health measure as one of your menu measures. And then the second one is the summary of care electronic exchange. There is a ton of questions about there, and I hope I'm following everything correctly. So one of the things that they wanted to do is take away the part of the measure that is focused on how you're doing the exchange. So they wanted to really expand the number of methods for exchange to create a culture of interoperability in preparation for stage 3. So they're basically saying we want to encourage people transferring information amongst different places of care, and we realize that by defining the method by which you can do that, we've made that harder. So we're saying it just needs to be created electronically and sent electronically. So that is very broad. I know some people have some questions about fax and other methods. It's my understanding that that is an electronic method, so you can, that would count towards meeting it. So those are my couple updates. I'll be on for the Q&A and cover a little bit more about MU at that time.
Great, thanks Beth. And everyone stay tuned for this free offer, right? Beth's going to talk through that too, and that'll be an opportunity for a number of you to have some real solid time with her and her team. As you can see, there's a lot of knowledge around MU. We're certainly dealing with it all the time for tens of thousands of providers on many different EHR systems, and hopefully some of you will be able to take us up on that. So thank you, Beth. Let's move over to PQRS. Value-based modifier, QRUR, all that stuff. Okay, so what I'd like to do is to break out several of the major ways for submitting PQRS and what you can do to really scrub those submissions before you actually do the formal submission. And the first, which we've often talked about, is this idea of which measures you pick can have a massive impact on what QRUR score is even possible for your existing data. And I'll talk a little bit more about that and remind everyone of that when we get to our free offer, because that's really a lot of what it's centered around, is how can you select from the myriad of measures that you could report for the data that you already have to get the subset that's actually going to maximize your score, and we have some interesting unique capabilities around that. So the other is, let's really talk about these audit triggers again. Again, these PQRS audits are really starting to ramp up now. And what we really found is really kind of going out there and talking to folks who've been through this type of thing, that a lot of it is around the denominators. CMS wants to make sure that you're actually including the patients that need to be in those denominators, and that you're also meeting certain thresholds on the denominator. So, for example, one common thing to be cognizant of is that when you file for registry, you may very well have multiple measures that actually have the same or very similar denominator. A classic example is denominator that's for patients, including patients that are age 18 years and older. For the alcohol-related measure, for example, it might be patients age 18 years and older that have some indication for that issue. And the very basic thing to check from your registry vendor is just to make sure, as a gut check, that those denominators that should be exactly equal across different measures really are exactly equal, and other denominators where they should be roughly equal are not like 10 times different from each other, okay? Because that's a real warning flag to CMS that there could be something going on there, and you want to make sure that you're representing yourself accurately, okay? The other part is not just looking among measures within the registry realm, but also realize that CMS has access to all your claims, okay? And CMS is what they can do and have done on their side is to look at the measured denominators that would be calculated from your claims for the same PQRS measure number as you're submitting using registry, okay? Because even though those are two different methods for PQRS submission, the denominators are often derived from the same claims data, okay, in your organization. So if CMS finds that you submit a registry measure value and it looks like the denominator is kind of low, like it may not be hitting the 50% threshold of minimum 50% of your patients in that measure, CMS does have the ability to look at your claims, apply a lot of the very same logic, in fact the exact same logic, to your claims and see if they come up with a denominator that is no more than double the size of the denominator that you're claiming to submit, okay? And there's been a number of audits that have actually occurred because of this. So be really careful. You're really getting 50%. There is a way for them to check that. You're actually getting the 50%, okay? And that's actually relating to this last point. The same logic applies really to the 20 patients that you need to get for the measures group measures, and using that subclass of registry submission using measures group, really be sure to capture the audit trail, on those 20 patients. Like you probably really want to be particularly careful because it's such a small number of patients. It's particularly susceptible to auditors going very deep with every patient and even wanting to know the dates of certain visits. Okay, so for those of you doing measures groups, it seems very easy. You can do it anytime during the year, but the audit trail part is be more careful about that part. Okay? All right. That's registry. All right, now let's talk about another popular way, which is PQRS G-Pro Web Interface Submission. So for those of you who do not know this or are about to do it for the first time, this is a way for G-Pros to submit group practices to submit as a group that you would have declared by June 30th of this year. And if you did select G-Pro Web Interface, what's going to happen is that CMS is going to open up, and I believe they have not opened it up yet, but someone might correct me on that. But every year around this time or after, they're going to CMS will open up the G-Pro Web Interface tool online, and you will use your credentials to log in, and what you'll see is you're going to see 17 different measures in there. And for each of those 17 measures, CMS will have selected for you typically 248 of your patients that are listed to you in a set order. And what you must do is you must go through that list of patients, patient by patient, without skipping any, and attest to the fact that you found these data elements that define the numerator, or that you cannot find any data, and you're legally attesting to the fact that you cannot find any data for that patient. You're moving on to the next one. Okay, so that's what that process is. It's very manual. It's highly error-prone, and it's very, can be very cumbersome. Now, what's important is that that you have no measure choice. You've got to submit data for all 17 of those measures. You cannot pick 9 of those 17. You got to do all of them. Okay. Now the question is what can you do to maximize your value-based modifier QRUR quality score with these type of constraints and with this type of data extraction process? I'm now going to walk through what that process looks like that we can suggest, and that in fact we can help you with. So first step is plan for at least 2 rounds of data extraction and input. And I mean have enough time in your schedule and your team's schedule to not just do the data extraction once and just be done with it. Plan to have 2 of them. And I'll tell you in a moment why that is. After the first round of data input, and you actually do that first round, you fill out data for all 248 patients for every measure, from the CMS web interface tool, you'll be able to run a report that calls the measure rates report. And you can run this report to preview your measure rates before you press the submit button. Now with those measure values is where the scrubbing happens. Is that the first thing you should do is to compare those measure rates, each measure's rate, against the 2015 VBM benchmarks. Okay, and those are going to be published quite shortly, within the next couple of weeks probably. So you'll have them well ahead of January. And to use that to gauge possible impacts to your QRUR quality score. Because for any measure rate that is going to be far below one of those benchmarks of values, that's where you have a risk point. Okay. Now you're probably asking yourself, well, what can I do about that? You know, the year's already over at that point. How can I move those numerators up? Well, it turns out that for web interface, you might have already gathered from what I described, is that it's a highly manual process that is subject to human judgment in terms of how deep you go in your medical record to try to get your numerators up by finding situations where a provider might have entered a lot of data and information into a free text field where you may not have looked at before. Okay? And so what you then want to do is when you do this type of analysis, and you take into account some other considerations here I just kind of have written, but I won't go into much detail on, is that you can basically find which measures may be most important to improving your quality score. And again, that's something that our free offer can help you do and give you a sense of based on your past performance. And then what you can then do is say, okay, go back to those key measures and even contemplate re-extracting the data for some of those measures that are particularly low compared to the benchmarks, or where you think you can do better on the numerator because the first time you did data extraction wasn't complete enough. Okay? And then really look at really look at the net result of that. Run the measures rates report again after that second round and really see where you're at. Okay. Now that's basically this is a fairly new technique, but a number of our clients have been able to use this to great effect. Okay. Now finally, the most rapidly growing way of submitting PQRS now is using your EHR. And EHR Direct is a mechanism whereby your certified EHR is required to be able to export to you a quality file called a QRDA3 file. And in that QRDA3 file, it contains all of your PQRS measures, which are all the same CQMs, clinical quality measures that you have for meaningful use, and it's some selected set of those measures that you want to submit, and you basically get that QRDA3 file either for each of your providers if you're filing individual providers, or you get a QRDA3 file that is for your entire tax ID if you're filing as a GPRO. Okay? Now the question is with that mechanism, what can you still do after the performance year is over to really help streamline it and perhaps even increase your performance even more? Okay, so now I'm going to talk through that. All right, so the first thing that we've often seen is that there could be some configuration issues in your EHR that can actually be fixed in the back office after the fact to actually increase your numerators that are now being depressed because of those problems. So for example, the EHR, the CQM calculation from your EHR might be configured where it's pulling data for the numerator from the wrong field, and that it's been a different field that your providers have actually been entering data into, and actually the providers are doing the work, but you're not getting any credit for it, okay? And so you want to look at some of those measures that you might be passing over now because you think the numerators are low, and really make sure that the CQM is actually properly configured for each and every one of those CQMs, because you might end up finding a measure that is much higher performing, and we've seen 10 times increase, for example. We've actually seen that in performance rates because of this issue, and you can actually do it even after the fact, and your docs don't have to do anything differently for this year. Okay? Now the second one, which is a little bit more technical, and it's a little bit more obscure, but it is a fact that a large number of the major EHR vendors had a big issue last year with trying to get their QRDA3 files in the exact right format that CMS would use, was using for submission. And the reason why that is because the version of QRDA3 that EHR vendors were certified for is unfortunately different from the version of QRDA3 that CMS will accept. And so these vendors had to do an additional set of development and testing to get the actual version of QRDA3 acceptable to CMS done in time for last year. And the bottom line is that there are technical issues with these files. Don't assume that you just get the file out of the EHR and it's just going to go right through. When you go to upload it, you want to ask your vendor, you want to even test it yourself, because the PQRS portal, when you log into it, actually has a testing tool. It's called the SCVT tool that you can use to test your file before you actually submit it, okay? The key is to do that as early as possible. And what you might find is that the QRDA3 file that you're getting from your vendor might be too large, because a lot of vendors put a lot of other extraneous fields into the file that make it exceed the CMS file limit. And you're going to want to really work with your vendor on doing that. It's something our firm also helps with. We work in conjunction with all the major EHR vendors in doing this. And there may even be syntactical issues. You know, think of a bracket that is missing the left, you know, the right bracket. Only the left bracket, you don't have the right bracket. Things like that that are just simple, really technical details that you don't find out until you actually try it. Okay, and that's really the main point there. You got to try to test that, or get your vendor to have verified testing of that file way before the deadline. Okay. Final thing, same for registry. Select your measures appropriately. You know, how can you maximize the score again? We come back to that when we talk to the free offer. Okay. So Beth, let's get right into the free stuff, the fun stuff. Why don't we talk through what we can offer to the first 10 providers, provider organizations regarding this assessment.
Sure, Todd. That was such. Sir, hi everybody again. I was still in PQRS mode myself. So I want to just offer to the first 10 provider organizations that go ahead and email me directly a free analysis of your MU program and the ability to answer any burning questions you have for your 2015 payment year. And when I say an assessment of your the organization of your MU program, we work with a lot of different clients, and one of the things that we talk a lot about with them is how to organize yourself so that you are more bulletproofed for audit purposes, but also so that you can reduce some of your administrative burden and kind of get your program on sort of an autopilot going forward. So we have a list of questions we'll talk to you about, just ask you and give you a little bit of an assessment and some advice. as well as just provide you some time to answer any of your burning questions. So that would be done via a 30-minute conversation via webinar over the phone.
Great, thanks a lot, Beth. Now, we're really focused on the eligible provider side of meaningful use, but would also invite those of you who just have general MU questions. We're always out for learning too, about the hospital side as well. Just as you can hear from Beth, she's really one of the leading authorities on meaningful use nationally. We help more than 12,000 growing very rapidly providers every year do their attestations on 15 different EHR systems, Medicare and Medicaid. She can tell you all about that, so please take her up on that offer. Beth at saignite.com. Send her an email. We'll look forward to hearing from you on that. Now, we're going to also put out there an ability to really analyze your PQRS data for VBM, value-based modifier. And so here's what we'd like to do. For the first 10 organizations that contact us at a link that I'll show below, this is what we're going to do. So we're going to basically look at your 2014 PQRS measures, because we understand that getting your 2015 data sometimes can be challenging. You're right, you're still not quite at the end of the year. So we can look at your 2014 measure values at a minimum from your 2014 QRUR, okay, which you'd have to basically do almost no work. You have to do no work for if you already have your QRUR, or very little if you haven't even gotten it yet. We can tell you how to do that. Just from at least your QRUR, possibly from additional 2014 measure data if you'd like to provide it to us. We can basically show you some analysis that can tell you whether or not scrubbing your 2015 PQRS submission could yield a higher quality score, and by how much. Okay, so we're looking forward to that. We had a great round of that in our previous offer, and while I kind of show you the links, and you can email me, because I know this tiny URL. It's tiny, but you still have to type it in. You can email me as well above, and I can email the link. But what I'd like to do is to actually, there's one of your peers, Wright State Physicians, who unfortunately was not able to be on the call today, that actually very kindly provided us a recorded testimonial, because they actually were the recipients of this type of analysis a month ago. And so what I'm going to do is to play an audio recording of Jenny Berkshire, and you guys can kind of hear it. So let me try to do this and get that going. All right. So we have Jenny Berkshire from Wright State, who is the Quality and Compliance Manager there, and I've invited Jenny just to share some of her thoughts about the pre-VBM analysis we conducted for her organization not too long ago. Jenny, how are you doing?
I'm fine, thank you, Tom.
Very good. Thanks for joining us. Please share some of your thoughts, and we'd really appreciate that.
Oh, sure, Tom. We received our QRUR, and as most people, found it to be a little complex and frustrating to review. I reached out to Tom through the SA Ignite webinars and received an interesting report back from Tom. We submitted our measures, our PQRS measures, through our EHR as a data submission vendor, and unfortunately CMS did not include that quality in the report. So we were looking at
Sorry, my phone just went to pause. Let me actually pick up that right at the punchline there. Pardon me. There we go.
Irrelevant information in our QRUR, and we received some advice from Tom, which we found to be very valuable.
I apologize. There's technical. Let me go back a little bit. I know, again, I don't want to turn this into a sales presentation, but let's go.
Jenny,
go ahead.
What is an example of something that you learned from the analysis we delivered to you?
One suggestion was reporting individually rather than as a GPRO, reporting individually with specialized measures, which they were able to point out to us, was a better method to report the actual quality. Using the EHR CQMs does not actually provide the actual quality of the physician. So using recommended values was very valuable to us.
Great. Thanks so much, Jenny. I really appreciate your time, and we're looking forward to continuing to explore how to assist your organization.
Okay, thank you all for bearing with me. Sorry about that. I didn't realize my phone was going to shut off right in the middle. But again, I apologize for that little glitch there. I think we really felt that with so little time left between now and submission season, we really just wanted to be very aggressive about putting these offers out there. I thought Jenny did a great job there kind of summarizing, at least for her organization, that there were really some very specific things that they learned where there was still enough time to do things for 2015. That was the main point. Okay, so again, didn't want to turn into a sales presentation, but with limited time left, we wanted to make sure we got the information to you guys. Okay, and we're willing to do this, so we're very happy to do this for the community. And hopefully you guys can take us up on it. So, all right, well, with that, let's go right into Q&A. A couple of links there for those of you who are interested. So, Carol?
Yeah. Can you hear me okay?
Sure can.
All righty. So, no surprise, we've got a number of questions lined up in the queue, as well as quite a few that came through the registration process. We will not get to everybody's question, unfortunately, so please, if you've got any questions related to MU, email Beth directly, beth@saignite.com, and of course, if it's PQRS, VBM, or MIPS related, or MU related, email Tom at saignite. So I'm going to dive right in and get to as many questions as we can with the time that's left. First question, can any eCQM measure be used to meet EP, MU, and PQRS with one submission?
Yes. The answer is yes. That really for all the CQMs, you're able to basically do a 2-for-1 in terms of submission for PQRS. Can you guys hear me?
Yep, can hear you.
Okay. All right. Sorry about that. That is absolutely true that for all the CQMs, it's not just some CQMs versus other ones, they can, is that yes, you can all do a 2-for-1 now. Now the interesting thing about that is that remember that when you submit using your CQMs using the EHR direct method or the DSV method, if you have your, let's say, your EHR vendor do it for you, really the same QRDA3 file. That's for an entire year of data that you have to submit for PQRS. Okay, whereas and if you do that, then you will, when you go to a test for meaningful uses, you can check a checkbox that says that you've already done it, but it's for the entire year of CQM data. So if you're doing a 90-day window, and let's say that you're doing that, or that you did do that during the middle of some year, then you don't have the full year's data yet. For PQRS. So just keep that in mind. But if you're doing it after the performance year is over, that's really when people take advantage of that.
Okay. A question for Beth. Can we use reports run in April of 2015 for MU to submit for calendar year 2015, or will the reports have to be rerun due to the final rule changes which just came out?
Yeah, great question. So you can go ahead and send that information from April. So you're absolutely able to use reporting periods that happened earlier in the year. You may want to check with your vendor to see if there are any differences whatsoever that they would recommend you wait and rerun the report. So you use the time frame, but you wait until your vendor has changed things via the modified rule. We have heard from many vendors that you can go ahead and still use the same reports, just kind of map the old measures into the new, but there might be some differences, so you want to check with your vendor on that.
Okay. This one's for you, Tom. Can you speak to combining measures groups, individual measures, and MU-eCQMs as PQRS measures for a quality strategy? That was a lot of acronyms, so if you need me to repeat it.
Yeah, sure. Basically, the questioner is asking to really talk about cases and reasons why you might want to have multiple PQRS submission methods either for when you're submitting individual providers, multiple individual providers, or even if you're a large organization, submitting PQRS for multiple tax IDs, for multiple groups within your organization. And it's a very common thing that we see. Specifically to that question is with regard to where it makes sense to report providers individually, where some providers you want to report using registry measures groups and others that you want to use CQMs, or in other words, EHR direct. The most obvious situation is when you have some providers who are on your ambulatory EHR, where really the vast majority, if not all, of their visits are logged on that EHR, then EHR direct makes a lot of sense as the first option to look at. Whereas if you have, let's say, some specialists that are not using a 2014 edition certified EHR, and you need to have alternate ways to report those providers, because you can't do EHR direct in that case, then you can really look at some of the other methods, and registry is the popular one. And the registry measures group in particular is popular because, as I mentioned before, is you can do it anytime throughout the year as long as you can get 20 patients data. Now you do have to swallow whole the entire measures group. There's an array of different measures group that are specialty specific largely, but once you select a measures group, you cannot then select measures within that group. You got to do the whole group or none, or do a different group. Okay, that's kind of one downside. And there's a lot of these subtleties around how do you select methods that is even relevant for providers who are reporting individually right now, because they can keep switching their method all the way up until the deadline. When we come to next year and we're all breathing a sigh of relief, hopefully, with regard to submission season being over, then we got to look ahead at the June 30th deadline for next year in terms of large organizations, or even organizations that have just two or more providers. We'll go through the same thing, is whether or not you should report as a group or stay reporting as an individual provider. Or if you were reporting as a group this year, do you want to still report as a group? As Jenny on that testimonial alluded to, is that her organization may have some real benefits of switching from GPRO to individual provider for next year, because it turns out they have a much higher ceiling on their QRUR score if they go individual provider. Okay, so that kind of a long, more comprehensive answer to the question was a great question.
Yeah, and used every acronym in the slide deck today.
we need a glossary. We all need a glossary for this stuff. Absolutely.
Oh no, that question missed the one I'm going to ask right now though, which is how can I improve my VBM scores?
Yeah, you know, we covered that, multiple different ways. The biggest one you can do at this time is to select your measures appropriately. Select your measures with some kind of an inkling of how it's going to affect your quality score for your next year's, or for this current year's QRUR that you get next year. Again, our free offer, covers that, and that's the number one thing you can do. And then the other part is that there are also, places where you can really improve your measure performance even after you've selected measures in the way I described, such as really looking at your numerators and your denominators, and really asking whether or not there are ways you can actually do better, in terms of how you extract data for those things.
Got an MU question. I'm interested in learning more about how to best meet the public health reporting for MU. Beth?
Yes, that is a common question. In short, for right now, you're likely okay because you're accustomed to having to meet that immunization measure or public health surveillance, depending on your state, which one you've chosen. So because the threshold for 2015 is such that you can take an exclusion for the other ones, for stage 1 and for stage 2, that you're likely okay for right now. What I will say though is you want to go ahead and get your name on as many lists as possible to get yourself registered with intent to participate in a registry. So find out which ones are available for your state, or you can even participate in national registries to have those count, because registering with those organizations will count for the measure definition of saying that you're in active engagement with those registries. So just by simply registering with them, you will get the count for active engagement.
Yeah. On a side note, our own Jim Tate did a post on High Tech Answers today, literally addressing this very issue, how to meet this measure for the 2015 to 2017 window. So if you go to High Tech Answers, it's the most current post that we published today, and Jim takes a look at that as well. In very detailed question here. In CMS FAQ 10660, it states that an EP, Beth, you're laughing, it states that an EP or EH can submit when a third-party organization is involved. This is an MU question. Can they submit via fax and email? Or email?
Yeah, I just know those numbers right off the top of my head, Carol.
Yeah.
So I did look this one up.
You
did?
I
did look up this one. And the good news is that CMS has further clarified that one. So part of what happened with that health exchange measure is that when it was previously published as part of the Stage 2 regulations, they were very specific about how the summary of care needed to be transferred. And so there was kind of a middleman there that many people were using. So what they're saying now is that if a third-party organization plays a role in determining the next provider of care, so you're sending your CCD or whatever to this third-party organization, and that third-party organization is then sending it on to another place, they can deliver that summary of care to the receiving provider by any electronic method, including secure email or fax.
Emphasis on secure, yeah. Right. Tom, a question for you. PQRS was aligned with CQM. Now that MU is changed to 90 days, that was part of the final rule versus 1 year, can we still submit CQM for 1 year and have it count towards PQRS?
So that's related to one of the previous questions that was asked.
Yeah.
Somewhat related, but I think the one additional clarification there is that remember that it is submitting PQRS for a full year using EHR Direct, which are your CQMs, that can give you credit for MU, but not the other way around.
Okay.
That attesting to your CQMs for MU does not give you any credit for PQRS. It's important to understand the one-way nature of this.
Right.
That's the only thing I wanted to add on top of what I already said before.
Okay. So what are the best options for reporting as few as measures as possible for specialists? Yeah. As few.
Yeah, that's interesting. You know, so that question begs a why question, right? Why would someone want to report as few measures as possible for specialists? And bottom line is that there's often a lack of data, you know, for specialists. It could be that they're rarely charting in the EHR. You know, that there are many reasons that many of you all in the audience are even more familiar with probably than I am. But there are ways that you can get away with lower number of measures. So for example, in the registry process, if you cannot find enough data to get to 9 measures across 3 quality domains, there is a process called the MAV process, measure applicability validation, as if you needed another acronym, right?
Right.
that you can, if you go through that process, and there's a decision tree whereby if you meet certain conditions, you can still avoid the automatic negative adjustments by reporting far less than 9 measures. Okay, so there are ways, but it's more complicated. You know, our recommendation has always been to keep driving your providers to use their EHRs to make sure they can meet that 9 measure threshold. Even if you're exactly at 9 measures, try to always go higher. Because think about what I said before, is that if you only have 9 measures, you're required to report all of them. That means you have no measure choice, and that's going to really tie your hands when it comes to trying to maximize your value-based modifier score. Try to go 15, 20. You need to have a broader pool of measures that have enough data to select from, so that you have more ability to maximize your reimbursement.
I've got one more, possibly 2 more questions, but one more for sure. Time for more. Will MIPS be rolled over to an inpatient? Well, the attendee typed INPT, which I'm assuming is short for inpatient. Will MIPS be rolled over to the inpatient setting, and what are the 4 programs that make up the composite?
Yeah, sure. So really quick is that I'll start with the last part of the question, is that MIPS, when it rolls out most likely in 2017, the RFI just closed, the request for information closed, is that there's 4 parts to MIPS. One is meaningful use, ambulatory meaningful use, which is 25% of the score out of 100 that each provider would score 100. And then you have value-based modifier quality score, which has been adopted as the quality scoring for MIPS. That's another 30%. Another 30% is from your QRUR cost or resource use piece. And then the last 15% is from clinical practice improvement, which is a new category. Now, with respect to inpatient side, is that strictly speaking, MIPS is a Medicare Part B payment adjustment program, so it does not adjust Part A payments. However, the ambulatory providers under MIPS who are being paid under Part B is, if you look at the different categories of measures under MIPS, which actually you can see in your QRUR right now, in the BBM piece, you can see that providers are being rated for certain hospital-based claims measures, such as readmission rate of their primary care patients. Okay, on the cost side, CMS is looking at the entire fully rated Part A, Part B, and in the future, even Part D drug cost side, full cost per patient. So what the takeaway from there is that there's got to continue to be better coordination with respect to quality and cost, even for these ambulatory providers, even though the payment adjustment is being applied to their ambulatory payments. Okay, so that's kind of a long answer to a shorter question.
Okay. We are just a few minutes away, and before we sign off, I want to remind folks that you guys, SA Ignite has set up a LinkedIn group, Merit-Based Incentive Payment System. You should go ahead and join that group. I know that we've got questions and whatnot. They've also provided a link where you guys deal with a number of FAQs related to MU, PQRS, VVM, and MIPS, of course, at saignite.com/resources-1. Also, just a reminder to check out the URL listed here, tinyurl.com/ob4c8xu, or email Tom at saignite for that free PQRS, VVM scrubbing analysis. And Beth has probably already gotten to 10 organizations already. I'm sure I've already emailed Beth. But for those of you who still have burning MU questions, maybe shoot her an email. I'm pretty sure she'll help you out or answer your question. And then finally,
I'll do my best.
Yeah. And finally, before we sign off, we're going to be continuing our webinar focus in this area. If you want, you can go to our High Tech Answers YouTube channel. Just go to YouTube, type in High Tech Answers, search on it, and you'll pull up and you will see all the past webinars as videos. You can also hear the podcasts of these events on our radio station, healthcarenowradio.com. So if you go to that URL and go to programs or podcasts, you'll find podcast of the Q&A portion. And with that, I think we're all headed into a holiday weekend with Thanksgiving, but I think we're going to be back for December. Is that right, guys?
I think that's the plan.
I think that's the plan. And by then, I'm sure we'll have 2 or 3 or 4 more acronyms. And before I go, I've got people chatting to me. Yes, we will provide I'll certainly get out in the next 24 hours a copy of the slide deck and a recording of this presentation. So no worries there, that will happen. And again, apologies for not getting to all your questions. Please email Tom at saignite or Beth at saignite if we fail to cover something that you would like to get addressed. Tom, Beth, just thank you so much again for your time, and I look forward to our December event.
Sounds great, Carol. Happy Thanksgiving.
Happy Thanksgiving, everybody. Talk to you later.
Bye-bye.
Thank you. Take care.
Bye.
All right. Bye.